So I'm going to talk about novel therapy, Ivabradine, and some practical applications. We have a few patients who are on the agents. So these are the objectives that I would try to achieve. I would revisit the case one, and then I'll add in another case. I would talk about the indication to Ivabradine in Canada, dosing, tolerability, and how you select between Ivabradine and sacubitril/valsartan in patients who are meeting criteria for both. And lastly, I would have some local data, Canadian data on the prevalence of patients meeting the shift criteria. So these are the approved indication of Ivabradine called Lancora in Canada, different in the US and in Europe. It's indicated for treatment of stable heart failure with a reduced ejection fraction of less than 35%, in adult patients with NYHA class 2 or 3 who are in sinus rhythm with resting heart rate more than 77 beats per minute to reduce the incidence of cardiovascular mortality and hospitalization for heart failure. So as you know, that Ivabradine should be administered in conjunction with standard chronic therapy, which include ACE inhibitor, beta blocker, plus or minus mineralocorticoid inhibitor, and it should be up-titrated under supervision of physician who experience with the treatment of heart failure. So reminding you the first case, he was a 66-year-old male who has NYHA class 2 symptoms from dyspnea, and previously a relatively preserved ejection fraction, but recently found to have ejection fraction that is lower. Please note that his blood pressure is 93/56, heart rate 78 beats per minute by auscultation, minimal ankle edema, Holter monitor confirmed frequent ventricular premature beats, and his creatinine was elevated, and his eGFR is mildly reduced. So as indicated, his ejection fraction is 28%. So he was on angiotensin receptor blocker, beta blocker, MRA, and it's oral hypoglycemics and diuretic. And I sent him to see an electrophysiologist for consideration of primary defibrillator, but the first thing they did was starting on amiodarone because they believe that the symptoms are caused in part by VPBs, which I don't necessarily agree. So this is the EKG. There's a lot of ventricular premature beats, but just believe me that the computer, and this is done twice, come up with a heart rate of 80 beats per minute. So the question that we are confronted is, should we start him on the Ivabradine or sacubitril/valsartan? Should we initiate therapy before or after ICD? Is a concomitant use of amiodarone safe? And this is what we did. We started him on the Ivabradine, 5 milligram twice daily. He consented for prophylactic ICD. He was seen 2 weeks later. He remained asymptomatic. Blood pressure was preserved. Heart rate down to 55 beats per minute. Ivabradine was therefore maintained at 5 milligram twice daily. The amiodarone treatment was maintained because he had no proarrhythmia. The ICD was subsequently implanted. And he was seen 6 weeks later. Blood pressure is still preserved. Creatinine is still impaired, but is above acceptable limit, eGFR 39. So he was started on sacubitril/valsartan at the lower dose. So the reason for what we did is the patient was in sinus rhythm. His heart rate more than 77 beats a minute. He was therefore suitable for Ivabradine. He had a low EF, so he could be suitable for Ivabradine as well as sacubitril/valsartan. He has borderline blood pressure and renal function, at least in the beginning. He's less suitable for sacubitril/valsartan, but more suitable for Ivabradine. The second case is an 85-year-old male who was diagnosed to have HFrEF for 5 years. He had CABG, and he had paroxysmal atrial fibrillation, but rare episode, and has NYHA class 2 symptoms. He had recent LVEF was 35% by marker scan. It already have a secondary ICD implant for ventricular tachycardia. He is actually hypertensive for a heart failure patient, and mild ankle edema, and creatinine is actually pretty good, eGFR 46, NT-proBNP 2,390. So this is his medication, beta blocker, mineralocorticoid receptor antagonist, a newer oral anticoagulant, ARB, diuretic, and a statin. So this is his EKG. He has a left bundle branch block pattern. He is in sinus rhythm, but his borderline QRS is actually specifically 130 milliseconds. So the question we ask is, should we start him on Ivabradine or switch him to sacubitril valsartan? When to initiate therapy, before or after CIT, or is he a candidate for CRT at all? So that's what we did. We switched his telmisartan, sacubitril valsartan at the medium dose of 4951 milligram twice daily. He was felt not to be a candidate for CRT at this point because of the borderline QRS. He was seen in clinic 3 weeks later, remained asymptomatic, blood pressure came down a little bit, heart rate was 72 beats per minute, potassium 4.4, creatinine and 135, eGFR of 40. The sacubitril valsartan was then increased to 98, 102 milligram twice daily, and that is the full dose. So this is what we did, why we did that. He's has relatively preserved kidney function and relatively high blood pressure, so he's a candidate for angiotensin neprilysin inhibitor. The history of paroxysmal atrial fibrillation would make him not a perfect candidate for Ivabradine, and he's relatively preserved EF, more than 35%, would make him a candidate for angiotensin neprilysin inhibitor. So the final point I want to make is Canadian data. We have conducted a study together with Sharon Roth in Scarborough General Hospital to look at some Canadian patients in the heart failure clinic settings. So this paper was published recently, and we looked at 1,096 patients with chronic heart failure from 2014 to 2015 in 2 clinics in Toronto, in St. Michael's Hospital, which is an academic university-affiliated institution, and Scarborough General Hospital, which is a community hospital. Shift-like characteristic is defined as ejection fraction less than 35% in sinus rhythm and heart rate more than 70 beats per minute. So these are the medications. A lot of patients, most of the patients have beta blockers, and the dose are table here. And but very few patients are in actually those targets as defined by their clinical trials. And shift-like characteristic, 35% of the academic institution and 30% of community hospital have EF less than 35%. Half of them in sinus rhythm, and half of them have heart rate more than 70. So transfer to shift-like characteristic, 8 to 10, 12% of these patients would have be prescribed Ivabradine when the drug is approved.